Thank you, Mr. Chairman. I would like to thank also the scientific committee for giving me the opportunity to give you this talk about HER2 pathway in gastrointestinal cancers. These are my disclosures. And if you think at altered pathway in cancer, generally speaking, we know very well that the receptor tyrosine kinase pathway, RAS pathway, is one of the most altered in human tumors, as you can see in this nice analysis from the CGA initiative. And if we focus on gastrointestinal cancers, this is the case also in gastrointestinal cancer. You can see that the receptor tyrosine kinase RAS pathway is altered in up to 88% of genomically stable colorectal cancer. And if we look within the pathway, there's no doubt that the HER family of protein is one of the most important altered in disrupting and giving this pathway an oncogenic potential. Now the HER family, you know very well the HER family of receptors. These are receptors tyrosine kinase type 1, consisting of an extracellular domain, a transmembrane domain, a juxtamembrane domain, and an intracellular domain with kinase activity. We know that the ectodomains of EGFR, HER3, and HER4 do have ligands interacting with these specific ligands, whereas no natural ligands has been identified thus far for HER2. However, HER2 can be activated by heterodimerization in a very potent way, even more potent than homodimers, and interacting with other ligands and giving rise to a potent oncogenic signal. Now, if we look again at all tumors and disruption of the HER2 pathway, you can see that you can find HER2 alteration across a variety of tumor, with the bulk of alteration in breast cancer, gynecological cancer, but also GI cancer. And if we zoom into GI cancer, you can see that the predominant histology is esophagogastric cancer, where you can find mainly amplifications. But then you have also scattered amplification throughout GI, also in CRC and in pancreatic cancer and in biliary tract cancer, for example. And it's important, I think, to note here that if you look at the MSI and the polymerase epsilon mutant subtypes of these tumors, you have a very high level or HER2 mutation, not amplification, but mutation. So we should take into account that these mutations do arise in the context of genetic chaos, and this is important, I think, also for using this as target of treatment, differently from HER2 amplification that is mainly a driver in these tumors. And speaking about mutation, we have data from the Summit trial. Data of the biliary tract cancer have been presented at the meeting yesterday. And this was an agnostic HER2-directed trial. And what happened at the end of the day, it was indeed a tissue-dependent response. And specifically in some GI tumors, in colorectal and gastric cancer, investigators did not observe any response with neratinib in HER2 mutant, whereas in biliary tumors, there was some more promising signal. And this, I just put it in at the very last minute. It's based on the results from yesterday, indicating that there is some response in this tumor type. Actually, we know from previous preclinical work that probably monotherapy is not the best way to go in this tumor type, and the combination with neratinib with another HER2 target therapy is possibly more potent, and as indicated in this preclinical work, and actually the Summit has been amended, and investigator will use this combination in the future. I will focus from now on amplifications, and it makes sense to start with gastric cancer, because in gastric cancer we have the most of the data with one approved treatment, this trastuzumab plus chemotherapy. And in this tumor type, you can see that you have amplification of HER2 more than mutation, and this is mainly occurring in the chromosomally unstable subtypes of gastric cancer that in turn is more prevalent in the G junction and proximal stomach than the distal stomach, and also in the intestinal rather than diffuse subtype of these tumors. Now, the clinical paradox that we all know is that following the successful TOGA trial with positive data and approved use of trastuzumab in this setting, subsequent trial were all unsuccessful, failing in demonstrating formally an overall survival advantages. Now, I think that here there are many issues, but the key word probably is heterogeneity. because in gastric cancer, it has been shown that heterogeneity can take place at the spatial level and also at the temporal level, with tumors lacking HER2 during treatment. And also, investigator as Memorial Sloan Kettering recently presented a very nice work showing that there is a substantial heterogeneity also in terms of concomitant alteration, like KRAS mutation, for example, that can preclude response. And this was also the case for those tumors turning out to be NGS HER2 negative at the moment of starting of treatment. So heterogeneity could really hamper treatment with HER2 target agents in gastric cancer. If we switch to colorectal cancer, it was really clear straight from the CGA initiative that HER2 is a recurring alteration in this tumor type. And if we put this alteration in the context of molecular subtyping of gene expression, we have that HER2 alteration, HER2 amplification, such as other oncogene amplification, are more likely to occur in the CMS2 classical subtypes with Wind activation, but also overexpression of some oncogenes. Now we have a more recent series indicating the exact numbers, the exact figures of HER2 amplification and mutation. In this wide series, out of more than 8,000 tumors profiled by an NGS commercial assay, it was possible to establish that you are in the range of 5% for both amplification and mutations, being amplification slightly more prevalent. So I would say that you have a kind of 3% amplification and 2% mutation. And in the Heracles study, out of 1,000 patients, what we found, it was 5% of tumors with HER2 amplification, but this was an enriched series because we tested only KRAS wild-type patient. Why is that? Because we know now that KRAS mutation are really underrepresented in a significant statistical way in HER2 amplified tumor as compared with HER2 non-amplified tumor. You can see 17% of KRAS mutation in HER2 amplified tumor versus the usual 50% in non-amplified tumors. Also, if we look at MSI as another important feature of colorectal cancer, you have that it's very likely in MSI tumor to find HER2 mutation, not amplification, and this is not the case actually for amplification. Now we reached in my institution 100 HER2-positive metastatic colorectal cancer that it was possible to clinical annotate this series, and what was clear as compared to consecutive control was that these tumors are more likely to arise in the left colon as compared to the right colon, as you can see here. This is not perfect, so the suggestion here to me is to test all colorectal cancer in order not to miss a therapeutic opportunity rather than only left-sided tumors, but you should consider that left-sided tumors are enriched for this alteration. And then these tumors also have more metastatic sites and are more likely to present with lung metastasis. Also, in this series, we confirm that HER2 may act also a biomarker of resistance to anti-IGFR treatment, as you can see here from this retrospective analysis. And this has quite solid, I think, preclinical data supporting this. This was the work done in the laboratory of Andrea Bertotti and Livio Trusolino in Candiolo, showing in this large PDX platform that indeed HER2 amplification were more likely to occur in the resistant patient to cetuximab as compared with a patient without this alteration. And it was taking advantage of this PDX platform that the founding hypothesis for the Heracles trial, therapeutic trials, was established, looking at the best combination for inhibiting growth of this PDX HER2 amplified, and it turned out that the combination of lapatinib and trastuzumab was the way to go for going into the clinic. But prior to embarking in a trial, we did a pathology study with our pathologist, and we established clinical criteria, pathology criteria for HER2, for scoring HER2 amplification in colorectal cancer. And as you can see here, there are some main features, U-shaped as in gastric, but possibly some better correlation between immunohistochemistry and HISH, and the cellularity of amplification more homogeneous, and also a lower intrasample heterogeneity. But what was most important is that we set the bar as high as 50% of cells showing amplification that is higher than as reported in breast and gastric cancer in order to reduce heterogeneity, but also in order to find those really addicted, HER2-addicted tumors. So result of the HERACLES trial with trastuzumab and lapatinib in refractory metastatic colorectal cancer have been published in 2016. Very high response rate for this heavily pretreated population, 30% of response rate, and also responses were durable. So, you know, with target therapy, sometimes responses are short-lived. What we observed in HERACLES is durable responses, and the longer tail here, you see this is a 72-year-old lady, now approaching 5 years of complete response. And also, we were able to show a discrimination according to the gene dosage. So the higher the gene copy number, and the better the response. And this was possible to be established also in plasma by liquid biopsy. Now I think that results of HER2 target treatment have been strengthened by the publication of the CRC cohort of the MY pathway. Here, 57 HER2 amplified metastatic colorectal cancer. Investigator reported 30%, again 32% of objective response. And what is interesting is that in this series you have also KRAS mutated tumors. So in HERACLES, we elected to exclude those patients because from preclinical work we knew that the KRAS was a biomarker of resistance to this treatment. But here, again, you see that actually this was the case. I mean, the clinical benefit was almost exclusively confined in KRAS wild type, as you can see also in the curves at the bottom. And it's very welcome, I think, that in the most recent NCCN guideline, trastuzumab and lapatinib is considered one possible option for HER2 amplified tumors in colorectal cancer. Now, the problem with target treatment is resistance, either acquired or primary resistance. And I think we are learning a lot, at least from HERACLES, from the blood, from liquid biopsy. And I would like to highlight some feature of looking at the blood with liquid biopsy for this kind of target treatment, because what we did, it was to analyze all samples of HERACLES in collaboration with the lab of Alberto Bardelli in Candiolo, looking for a baseline liquid biopsy and a liquid biopsy progression. And what was very important, I think, is that by liquid biopsy it was possible to detect some RAS and RAF mutation that were not there by analyzing only the tissue. And these were really enriching refractory patients, meaning that with this kind of diagnostic tool, you can really also enhance the therapeutic efficacy of this strategy. Also, and also very importantly, it's the very first time that at secondary resistance, it is possible to show that in colorectal cancer treated with HER2 target treatment, you have the onset of HER2 mutation and PIK3CA mutation, very much like breast cancer, but also, and this is more peculiar to colorectal cancer, also KRAS mutation and BRAF amplification, for example. Now we examined, of course, all patients in HERACLES by RECIST criteria, but you know that these criteria are increasingly felt unfit to monitor targeted treatment because sometimes you have very heterogeneous response, like this is the case of this patient in HERACLES with a liver lesion continuing to respond and another liver lesion progressing. So this patient was subjected to the DONU protocol. This is a warm autopsy protocol that is running at our institution that enables rapid processing of post-mortem tissue sample. And these samples were, each sample from a metastatic deposit was analyzed by whole exome sequencing by the laboratory of Alberto Bardelli, showing very different pattern of evolution of any single metastasis. And also, this is a very complex work, but what is interesting is that by liquid biopsy, it was possible to track the dynamic of this lesion, and this was really associated also with the radiologic evaluation of every single lesion, making liquid biopsy also a promising tool also for monitoring treatment and not only for selection of patients. Now, finally, we have also data from biliary tract cancer, because here HER2 can be detected amplification in a percentage as high as 15 and also 20% in some series. We have data from the MY pathway cohort, pertuzumab and trastuzumab, with a very promising 29% overall response rate, and also a previously reported series with gallbladder cancer achieving a very high response rate. But this is a very heterogeneous series with monotherapy and anti-EGFR anti-HER2 monotherapy and also combination with chemotherapy. Small number, but in this histology, probably there is a role for HER2 treatment. Finally, what are the future avenues for improving results? I think there are 3 avenues. Using more potent drugs in terms of small molecules, and tucatinib is under evaluation together with trastuzumab in the Mountaineer trial, for example, in colorectal cancer, and also immunotherapy. We saw at ESCO promising result of PD-1 and PD-1 blockade in gastric cancer in front line together with trastuzumab, but also more innovative strategies like bispecific antibodies like cetuximab is under clinical evaluation for gastric cancer, and HER2 vaccines. We will see tomorrow presentation of the IMU 131. Among antibody drug conjugate, I think that trastuzumab deruxtecan is a very promising compound because it has a better payload than trastuzumab DM1, and also it conveys a topoisomerase 1 inhibitor that is probably more suitable as for efficacy in gastric and in gastrointestinal cancer than a tubulin inhibitor. So my conclusion are that HER2 is a well-known oncogenic target in GI cancer, and we know that the actionability of amplification in gastric cancer, but now we have results also for colorectal and initial results also for biliary tract cancer. As for mutation, also, these are actionable targets, but there is a tissue-dependent response, and here probably there's a more selection according to a more fine-tuning should be made in order to have better results. And I conclude my talk by thanking all investigators and colleagues involved in the HERACLES initiative. Thank you very much.